Hello. So, as we are delving more and more into psychiatric illnesses, and some of which you must be knowing and some of which you learn as you move around in neurosciences and your medical career or psychology. So, more than depression and schizophrenia and dementia, the word which you would have heard, and I am sure you would have experienced this word called anxiety. And some people may actually say that all human beings live in anxiety, perpetual anxiety all the time. So, is this anxiety normal or abnormal? So, before we talk about anxiety as a disorder, let us look what is the normal versus pathological anxiety. Normal anxiety is normally very adaptive. It is an inborn response to threat or to the absence of people or to objects that or the environment which provides you safety. So, any absence of this can lead to either a problem in thought, which is worry, or a physical symptom, like some of them are mentioned: racing heart, sweating, shaking, drying of mouth, tingling sensation. These are physical symptoms of anxiety, and continuous worry, not at the level of thought, thought must be there, but apprehension that something will happen, something will go wrong. You all of us have suffered this. Imagine with just sitting before your exam, just before you receive the, it is an important exam, and just before you receive the question paper, your heart is really going, unless you have really trained your mind to be very cool or given so many exams that your mind becomes cool. Believe me, even the most trained of speaker, when he gets onto the stage, gets this anxiety. This is the normal adaptive thing. To avoid this, you prepare well, you study well, you reach in time, so that you do not miss your exam, you keep yourself healthy, so that you can, you take all the precautions to reduce the threat of damage to it. So, human mind, as I told you, normally functions to remove the threat and keep you safe. The pathological anxiety is excessive and it impairs your function. So, if it is often said that anxiety and performance have almost what you call a Yerkes-Dodson curve, which like this. So, as anxiety increases, like goes like this, your performance comes down. So, little bit of anxiety here, your performance is going up. It increases certain more, it will come down. So, having said this, now you know what anxiety is all about. So, then you can ask me whether anxiety is an illness. For some it is. Excessive anxiety to a small insignificant stimuli or absence of stimuli, or even to a real threat which impairs your functioning, is called anxiety disorder. A larger term, there are many sub syndromes into it. So, what we find with anxiety disorder, that it has an early onset. There is normally 2:1 female predominance. Now, whether this is biological or has been induced by the way females have been treated in the history, is something which is debatable. There is a fluctuating course. Anxiety, unlike schizophrenia, is not permanent, it is not going on and on and on. It comes down, comes, goes, improves, people survive, they again have this. There is a lot of functional impairment when anxiety is high, and the quality of life is, imagine, and all the time if you are apprehensive, slightly shaky, you do not know what is happening, it can lead to lot of impairment in your quality of life. This is one of the not we have not been able, in spite of the best of the imaging and electrophysiological. Functional MRI has given us huge information. We broadly know which areas in the brain control thought, or where does the thought process, but all that is still very vague, we still can't pinpoint. Otherwise, we would have formulated devices to tell you which may come up in next 20 years. But one of the robust finding of neuroanatomy and neurophysiology and neurosciences is there is a structure called amygdala, tucked deep into the limbic area, which is involved with the processing of emotional stimuli. So, if the anything external which comes, if the salience network, the network of the higher cortical center going down to the limbic to the emotional area, senses that something is threatening, and this has come from evolution. So, these three area which amygdala, medial prefrontal cortex, which includes the anterior cingulate cortex, the subcallosal cortex and medial frontal gyrus, and hippocampus, where we talked about hippocampus in memory when we were talking about dementia and the damage to it. They are involved with processing of this stimuli. So, if amygdala takes some feature and senses it through the comparison with the memory encoding, and it feels it is dangerous, it will suddenly induce fear. Now, the fear itself will be controlled or not controlled is done by these areas, medial prefrontal cortex. So, this is the whole circuitry. This circuitry probably fires or misfires in people who have anxiety. If it fires in the way that it keeps in touch with reality and keeps you prepared, and your higher centers are able to control this hyper vigilant and arousal, then you are able to function as according to that curve. But if it goes beyond control, the whole control system goes into a sort of derangement, with these symptoms and these features of your mind take over the. Now, you can ask me whether this is also psychotic, because obviously you know that you should be functioning, but you are anxious and you are not functioning. So, isn't it a loss of touch with reality? It may appear as a loss of touch with reality, but it is not, because your insight is preserved. Your mind all the time knows while this is happening, especially in a panic attack where you feel that you will die, but you are feeling, but you still know you are not dying. Whereas, if a schizophrenic person, a person with schizophrenia hears somebody talking to him, he will believe that voice, he will believe that voice. So, that is called insight. All insight is preserved. So, when you look at it, is the primary versus secondary. The primary anxiety disorders, secondary can be with substance abuse, with alcohol, with cannabis, medical condition. There are certain conditions of heart where the symptoms actually, there is a tachycardia and there is something called PSVT, paroxysmal supraventricular tachycardia, which can send your heart into fast beating suddenly. This can mimic overlap anxiety. Medical conditions, thyroid, hyperthyroid, psychiatric condition, other psychiatric. A patient with schizophrenia can have anxiety, a patient with depression can have anxiety, and psychosocial stressor. So, what are the anxiety disorders? You would have heard all these terms, believe me. You would have term called phobia. Phobia is the excessive irrational fear of a situation where it can be queue related. Some people are fearful of closed lift or closed rooms. So, claustrophobia, there is a whole list of it, is often asked in general knowledge questions, of heights, something called agoraphobia. There is something called panic disorder, social anxiety, anxiety disorder due to general medical condition. So, phobias, some of them are genetic, like blood phobia and social phobia, which can lead to something called social anxiety disorder. All of us, when we are growing, so have certain amount of social anxiety, but for some people it becomes a social phobia. So, phobia normally is characterized by irrational excessive fear. Even if you think of that situation, you can start feeling anxious, which is called anticipatory anxiety. And because of this, people tend to avoid those situations. Like if somebody is fearful of height, they will always avoid going to that place. So, this avoidance behavior, the anxiety, whether that phobia is in real, that cue is in real, that stimulus or situation is in real or in your mind, can always create anxiety. This is just a chart showing the distribution of anxiety disorder. So, for panic disorders, generalized anxiety, OCD is obsessive compulsive disorder, we will talk about this in the lecture, and phobias, there is a significant family history. So, people who develop all these illnesses, what has been found that there have been histories of people having similar or sort of a spectrum from mild to moderate or different type of connected illnesses in the family. So, there is a heavy genetic loading. Twin studies have found heritability of 0.43 for panic and 3.2 for generalized anxiety disorder. Now, specific phobias, commonest snake, blood. You have seen people seeing blood and going dizzy and falling down, or with snake they are panicky, or with closed spaces or height. You would have seen a film called Vertigo by Alfred Hitchcock. It is a typical case of fear of heights. This is a marked or persistent fear which should be more than for 6 months. Now, it can have onset any time. Some people are fearful of traveling in aeroplane, some people are fearful of riding the train. Excessive or unreasonable, cued by the presence, as I said, or anticipation of the object. So, even if you think, you will get fearful. Anxiety must be out of proportion to the actual danger. So, even if you go to a height, or you are closed in a lift, or you are caught in a market, agoraphobia is typical, and they all onset panic attack. Agoraphobia is if you go into a marketplace and suddenly your mind tells you that what if the whole thing collapses, what if there is a crowd and I cannot escape. Nothing is happening, it is just the whole, the geometry of the place, the pattern of the geometry probably, which goes into your brain and it triggers off. Now, it is possible that sometimes the learning theories say that all this is learned. It is possible that some point of time the snake may have really crawled over your leg, and that would have induced sudden anxiety in your head, which is saved in the memory. So, even if memories are formed by reverberating circuit and lot of rehearsals and in the brain and brain firing and consolidating and changing synapses, it is known like something called post traumatic stress disorder, with a sudden natural calamity or a man made calamity creates such a amount of disturbance in your brain that synapses alter, and that is a memory, like we saw in hippocampus, and that every time the salience network sees that thing, it will trigger and compare with the memory, and the memory will tell the amygdala that this is the thing which was fearful, and amygdala will start a fear response or a rage or. So, this is all a electrochemical circuitry which is firing. We try to treat it with drugs and improve the firing patterns and all, and it interferes with the person's routine. 15% of general population is a huge number. Early in life, females again more than that. Etiology, as we said, it is a learning or contextual conditioning. So, it is a response which the brain has learned, and because the brain has learned this response, that is why it every time it responds to that. Some of the actually the treatment which we call a systematic desensitization. So, look at it, the word itself explains the whole thing. The explanation is that the mind is sensitized to a certain cue or object, whether in real or imaginary, and every time the memory and the amygdala compare it with the pre-existing memory, it sends a panic attack or severe anxiety of whether physical or mental kind. So, what you have to do apart from medicines, which we will talk later, you have to see what is the ABC, like the antecedent, the behavior and the consequence. The antecedent is that cue, imaginary or real, behavior is anxiety or escape from that or avoid that situation. The consequence is you save that anxiety if you do not expose yourself. So, what we do is called systematic desensitization, and they normally do not occur in a single phobia, they can be multiple. So, create a hierarchy of list of the situations where the person feels anxiety, and train the person to desensitize from that cue. And as they move on into the hierarchy, they will come to a situation where the phobia will disappear. Psychologists know this, it is one of the most common techniques. Social anxiety disorder. We all, when we are developing, develop during the developmental phase, develop anxiety of performing, of meeting people socially, but most of us go through it. We just overcome it and move on in life. But people who have social anxiety, which can almost go to social phobia at times, when they start avoiding like other phobias, they have this fear that when they are talking to somebody, when they are meeting somebody, they are always fearful that they should not say something or they should not do something which will embarrass them. It is like looking at yourself from the eyes of others all the time. And this behavior, once sometimes in one or two situations, all of us undergo this. But when it becomes a disorder, then people avoid situation. The more they avoid, see, all anxiety disorders are like self propagating. The more you avoid, the fear becomes more established. The more you avoid meeting people, the fear becomes more established. Every time you give an exam and you start bothering about the result rather than the performance, suddenly it gives you a panic attack, and that anxiety overcomes your normal functioning of the brain and you perform bad. These are a lot of kids whom you will know, who study and mothers say they are studying well, but they do not perform. Some of them have performance anxiety. When they see the paper, the whole mind goes into a tizzy and they really do not know what to do. Again, it is a learning, a biological circuit and pattern of firing which goes on and on every time it happens. Exposure to the feared situation, as I said, is almost invariably provokes anxiety out of proportion, and just for diagnostic purpose we say it is more than 6 months. Again, it is socially impaired. A lot of these people have, they are not able to perform to their potential, they are not able to mix freely. Now, here when we are talking about social anxiety, we should differentiate it from another illness called schizoid, which is a part of personality disorder. We will talk about personality disorders if we get time. Schizoid personality people also do not meet people, and they are mostly in their own world. They are adults, they are different from autistic kids, they interact normally, they can talk normally, they keep doing their work, but they do not have an inner desire to make friends. So, their social circles are very, very limited. Contrast this with a person with social anxiety who wishes to make friends and is always aware that he is socially isolated, wants people, but is not able to make, because every time he steps out of his own self, or every time this person wants to interact, this social anxiety or being judged from the eyes of others, or being fearful of making some embarrassing move or sentence stops him, and that perpetrates till it becomes like almost social isolation. So, this is a pretty high incidence of 7%, and teenagers mostly have it, most teenagers grow out of it by 13 and 90% by age 23. And obviously, when you talk of increasing depression, it has to, because if you are socially isolated, because whatever we know of human brain, one thing that is certain, that human beings are social animal, we all know it, and social relationships, being in close contact with people, having a trusting relationship, being able to express yourself freely without the burden of somebody judging you, all that is human. Right from your childhood, from your early first day in life till all your life, till the end of your life, all of us need validation from society, from friends, from people who will accept you as you are. Imagine a person, and just imagine the misery of these people. A schizophrenia patient is living in a different world, not able to perform, still having lack of insight, depression, miserable feeling of sadness. Worse than that is anxiety, because you know you can do it, you know you have nothing which is inferior to the other person. You need validation, love, but you just cannot open yourself. So, if you look at the fMRI, try to compare with what they are saying, they, while reading stories that involve neutral social events, unintentional social transgression, choking on food, then spitting out in public, or intentional social transgression, okay, both groups had increased activity in medial prefrontal cortex in response to the intentional relative to unintentional transgression. However, showed a significant response to the unintentional transgression. They also had significant increase in the amygdala and insula, as I said. Now, insula is one area. So, these areas we mentioned. So, when you are looking at almost unintentional, like you are eating and you choke and then you spit out on public, or is the intentional transgression, disliking food and spitting it out. You eat and you say you do not like it. So, there is a difference between it. So, there is an increased medial prefrontal when there is intentional transgression, right, because it is trying to control the modulation, but unintentional transgression also keeps them slightly on the edge. Insula is one area which, as I mentioned, if you remember while we are talking about the anatomy, which talks, and the whole investigation indicate that this is the area which controls empathy, the mirror neurons. Empathy may be a higher cognitive emotion, mirror neurons. This area tells you to read the emotions of the other person, whether it is, even if there is no verbal indicator, you can still make out what people are feeling. So, insula is hyperactive because already on the edge in social anxiety, always reading the mind of the other person, trying to see what is the expression of the other person when they are looking at me. So, again as I said, these are the fMRI things. They have shown hyperactivity of the amygdala even with a weak form of symptom provocation, namely presentation of human faces. So, even if the presentation of a human face can trigger off, it can just trigger off the whole anxiety thing, because that is what is the problem. They are always cautious that they should not do an embarrassing thing which will separate people from them. So, it is like a counterproductive thing. You want to make a friend, all the time you are worried that I should play to the gallery, I should be like this to show that the other person does not leave. This creates a huge pressure, you are always on the edge and you end up doing something and you become more embarrassed. Next time you get almost phobic to it, you almost avoid it, and that creates a cycle of social withdrawal, isolation and depression. So, the treatment is like, one drug is called citalopram, we will talk about the drugs which are very common drugs, or cognitive behavior therapy, which has also shown reduction in the activation of amygdala and hippocampus. This is a proof for learning theory, that as hippocampus and amygdala, they have learned to avoid this situation, to be anxious in social situation. This is all a learned behavior which may have happened or may not have happened. If you train these circuits, then the activity decreases over time. This is a proof that the mind can be trained. We may not have been able to find out things for schizophrenia still, but in these things, social skills training, behavior therapy, like exposing yourself to a situation and avoiding the response. The response is run away. You expose a person to a social situation, train him to tolerate the anxiety, not run away, which is the normal response, and by repetitive exposures, this response of running away will decrease, and so will the anxiety. Social skills, some people stammer in such situation, some people avoid situation because they feel they cannot assert themselves or put their idea across. There you have to teach them. They are effective medicine, and cognitive therapy obviously is a part of treatment, as we have talked before, which trains you to alter your thoughts of some. These minds normally magnify a small look at somebody's face, which may be just an innocuous thing. This, and if somebody is looking face to face, their mind may take it as a, oh, this person does not like me, it magnifies. So, this minimizations, magnifications, the selective abstractions, when you are anxious, you will look at things which will heighten your anxiety. So, you will not really bother too much ki, okay, this is like, let it pass off. So, cognitive therapy helps there by altering your thoughts, your cognitive aberrations. Medications are, as I said, we did not talk about antidepressants. These are group of medication which help decrease anxiety. Benzodiazepines, this is a group of medicines, a common medicine which you would have, alprazolam, diazepam, clonazepam. The SSRI is a selective serotonin reuptake inhibitors. SNRI is a serotonin norepinephrine reuptake inhibitors. Monoamine oxidase inhibitors. Now, all these drugs are chemicals, synthetic chemicals which go in the body, are absorbed, go to the brain, act on certain chemicals which have been implicated in anxiety disorders. Now, some of them are also implicated in depression and in other illness called obsessive compulsive disorder, which we will talk about. So, they are given in different doses depending on the severity and the duration which a clinician can decide. Benzodiazepines are not a long stay treatment, but till the modern medicines were developed, they were the only medicine. They immediately help in anxiety. So, a lot of these people they almost become dependent on that, because they know every time you feel anxious you pop up one benzodiazepine and it will immediately decrease, because benzodiazepine work through a chemical called GABA. You would have heard this word previously. The GABA is an inhibitory chemical. So, what is the problem in anxiety is the hyperarousal and activation. GABA, which comes mainly in the cortical layers, decreases the activity. So, GABA, any drug which goes and increases the GABA actually decreases the firing of the other neurons, which in turn decreases the anxiety. Whereas, these medicines they go and alter the chemicals through which the firing patterns are decreased. Panic disorder is a recurrent unexpected panic attack, and for a 1 month period or more persist. So, as I said, anticipatory anxiety, worry about having it, worry about the implications, significant change in behavior. Panic attacks are very typical, and they incapacitate almost. A lot of cardiologists see panic attacks. The person suddenly feels or lasting within 10 minutes, severe feeling of anxiety, palpitation, choking, trembling, and they feel as if they are dying, chest pain, chills, derealization, they feel as if something has changed and it settles down. Fear of losing control, it can settle down in 10 minutes, but what happens is that people get so agitated that the panic attack settles down, but it is like a tail which goes on and for 2 hours. So, it affects 2 to 3%, is a very common thing. It is an intense fear of dying with physical anxiety, choking, trembling, paresthesias, derealization, that nobody dies of panic attack, but in panic attack people can jump and hurt themselves. So, it is a very common thing, 2 to 3%. Female ratio again, as I said, a panic attack is not equal to panic disorder. One single attack of panic usually we do not treat. If people are having more than 4 episodes or 2 episodes in a month, then it has to be treated. A panic disorder has a waxing waning course. It can happen now, it can happen after 1 year or 2 years or 2-3 episodes in a month. So, 50-60% have lifetime major depression, 20 to 25% have history of substance abuse. Drug, genetics of it, social learning, cognitive theories, neurobiology, separation anxiety can cause. Treatment is very effective, 70% improve, avoidance of caffeine, alcohol, cognitive behavior therapies, and the same group of drugs we were talking are really very effective. We will talk about it in detail when we talk of another illness. And so, we will continue this in the next lecture and we will talk about something more. Thank you.